It is great to be here. I can't believe I've never been here. I don't know.
Didn't know that?
Yeah,
Never
I don't
in this
know.
building?
No, I mean never at TRI, never. Right. So it is a pleasure to finally make it here. I've been hearing all about you guys for many years, of course. I think Tom doesn't give a talk without showing the triangle, right? A pyramid. Okay, the pyramid. So I didn't bring the pyramid. But I know you all know what it looks like, and so I'm going to pretend draw it right here. So there's the pyramid, and usually I talk about the part that Tom likes to emphasize, the people who are at risk for problems but don't yet have problems, or the people who are at risk and have some problems but don't yet meet criteria for a diagnosis. And today I'm not going to talk about those people. I'm going to talk closer to the tip of the pyramid. The tip of the pyramid, the people who have addiction or moderate to severe substance use disorder. But Mark Willenbring, who used to be at NIAAA, used to like to point out, or still probably likes to point out, that most of what we know is about treatments in middle-aged white men who are at the very tip of the triangle, and not only the ones who are at the tip of the triangle, but those who then volunteer for studies. Well, they want treatments and they volunteer for studies. So I'm going to not be just in that tip. I am going to move down a little bit to include discussion of people who we find out there who have these conditions that may be moderate to severe but aren't necessarily seeking treatment. And some of those folks are included in the studies that I'm going to talk about today. The second thing, so I've titled this Chronic Care Management for Addiction, What Can We Learn from Failure? Another subtitle might be, is it possible to take 7 or 8 years, $5 or $6 million, train a lot of people, have lots of clinicians working as hard as they can to take care of people with these conditions, and compare that to treatment as usual, which is not much, and find no differences? Is that possible? So that's the subtitle. You may have already guessed that it may be possible to do that, and that we've achieved that up in Boston, where we're so good at this. So these are numbers that you probably know. They come from data from SAMHSA, and also, so one is, the usual is cited around 5 to 10% of people with substance use disorders get any kind of treatment if you look in the past year. And then the next one is from Beth McGlynn's work at RAND. The 10% is of people who have a substance use disorder, this was actually alcohol use disorder, documented in the medical record by a physician. 10% have something done about it. Something could be we advise them to do something, or we try to link them with care. 10%. 90% don't. I was telling this to somebody who's sort of outside our field, a PR person at our institution just yesterday, a couple days ago. And she was just so shocked, because if that were the number for diabetes or for heart disease, people would be marching on the Capitol steps. And so I'm just setting up the problem for why integrated care might be a good idea. Then there are folks who do go to get some treatment, and of those that do that, about half of them it's detox, and of those who come out of detox, probably less than half, maybe closer to 30%, end up going on to something else. And then of those that get into some treatment, 50% of them complete whatever complete is, as if treatment could be somehow completed. So the numbers are not good. The numbers are not good, and there's got to be something we can do about it. And of course, I'm suggesting that maybe integrating into the general health system is something that might be able to address that. And Tom did a study that you guys are probably all familiar with, maybe, I think it's actually 10 years ago now that it was published in Journal of Substance Abuse Treatment, looking at specialty substance abuse treatment programs. This is where we should be doing our best, right? These are places where specialists are delivering supposedly all the best treatments. And we know, for example, that medications are among some of the best proven treatments for addictions, and yet in a large proportion of those programs that Tom surveyed, they didn't have someone who could prescribe. So you don't even have the ability to deliver one of the treatments, and these are specialists, so they ought to be able to deliver all the treatments, right? If you go to a cardiologist, they don't just pick and choose some treatments they're going to give. They're capable of delivering all of them. And the way that we have things set up, we're not. I made this into a triangle Venn. I think it's still called a Venn diagram, even though it's not circles. And I use triangles because if you use circles, the part that's overlapped is actually really, really small. And the point of this one is that the part that's overlapped is not small. That people who have addictions often have other mental health conditions and medical conditions or other medical conditions. And not only do they have these three areas covered, a lot of these are chronic conditions that have to be managed longitudinally, and they affect each other. So if one of them is out of control, you can't get good control of the other. So if you're using too much cocaine, your diabetes may be out of control, either physiologically or because you're not showing up for your diabetes care. If you're too depressed, you can make up, I'm not going to go through, you can make up how one affects the other. And so taking care of them all in some sort of integrated way, chronically, over time, makes sense. And there's lots of references there, and I guess you guys will have the slides, and you're going to have video so that you can look up any of those references that support that, but tons of references on that. And then the Institute of Medicine recognized this. Did you chair this? I know you were on this, Tom. I don't remember if you chaired it or not, but you don't remember either. But the Institute of Medicine recognized this and made recommendations about how to improve the quality of care for people with mental and substance use conditions, including integrating care. And so it's a good idea. It's a good idea. Integration is a buzzword now, and if you look at health reform around substance use, mental health, this is a big deal. SAMHSA has an entire center and website, the Center for Integrated Health. There's an S. Solutions, maybe? CIHS, something like that. Big website at SAMHSA that's got all kinds of resources on integration. It must be good. It must work. It's the best thing since that, right? It's the best thing. So what's the evidence? Since we know it's the best thing and it's already going to be being paid for and widely disseminated, and by the way, it is costly. It's a big deal to do integrated care. So there must be lots and lots of evidence showing that this works. Well, Butler, so down the bottom, Butler did a report for the Agency of Healthcare Research and Quality and found not much evidence at all for integrating into general health settings, integrating mental health and substance use care, integrating substance use care into general health settings. He did find two studies that he characterized as, and this is casting no aspersions, backwards integration. And backwards integration means, I guess it was a classically physician medical perspective, integration of medical services into addiction treatment programs. So there were a couple studies, a couple of randomized health services trials that did that. One was done by Mark Willenbring and published in the late 90s in Archives of Internal Medicine, and he took veterans in a, quote, alcohol clinic, and these were medically ill veterans. They had medical conditions related to alcohol, and they had in this clinic both of those things taken care of. Their liver disease, any other medical conditions they had, plus their alcohol dependence. And he found that group, compared to usual separate care, which was you could get your alcohol treatment at the alcohol clinic and then you could get your medical treatment at the medical clinic, that they did better. They were more likely to be abstinent by about 9 percentage points, and they were more likely to, less likely to die, in fact. There was a mortality difference that was statistically significant. It was a relatively small study, but really pretty interesting. And then Connie Weisner brought medical treatment into an addiction treatment program at Kaiser in the Pacific, in the San Francisco, in the Bay Area. And she found in the subset, not overall, not in overall analyses initially, but in the subset of people who had what she called substance abuse-related medical conditions, in that subset of patients that having integrated care versus having usual separate care was that those folks were more likely to achieve abstinence during the course of this 5-year study. So again, pretty promising backwards integration. And one of the things with backwards integration is you don't expect that you're going to be getting the majority of your health care in an addiction treatment program for your whole life. Even if it is a chronic condition for you, you may not need to get that intensive care for your whole life, and so it's a little odd. I mean, maybe it's a good idea to integrate in the short term in addiction treatment, but I think what we really want to know is what if we integrate it into the general health setting, because that's where people are going to be going back to get their care. So that's what we thought in the early 2000s, and a bunch of grant applications to several institutes later, we were awarded funding to do this study. It's a long saga that ends up with publication of the results in JAMA, and because you guys are researchy, I'm going to give you lots of detail about the study. But I would call this the Cadillac model, and we called it the AHEAD study, which was addiction health evaluation and disease management. And we use these terms, disease management, chronic care management, and integrated care a little bit interchangeably. They're not quite. Integrated means doing it all in the same place, maybe by the same team, same practitioners. Disease management sometimes is confused with what insurance companies do by calling people on the phone and checking if they've gotten their medication. And what we mean here really is chronic disease management or chronic care management based on the work of Ed Wagner in the Pacific Northwest, where there are a bunch of elements that I'll show you what they are because we implemented them in this study. Let's see. So a lot of people, it was expensive. Here's the expensive part. All these people worked to implement this study. It was funded by both NIDA and NIAAA, and then we had lots of study participants, which I'll tell you about, but this was our team. And if you want to look up even more details in the online appendices and all that, you can do that. If you go to the JAMA website, look for September 2013 or my name. You can see me in a video. It's really fun. But you can actually see me live today or on the video there later. So don't worry about this blurry part. It's just to remind me to tell you something. But these are the elements over here. These are the 7 elements of chronic care management that Ed Wagner described. It's focused on the patient. It makes the chronic disease a priority. The patient gets to do something themselves to help themselves. You have to change the delivery system to make sure that the care gets delivered appropriately. You help the clinicians by letting them know when they ought to do something and maybe even what they ought to do if they're not sure. Clinical information systems have to support care, and then you make use of community resources around you. So that's what Ed Wagner described, and we wrote a review article calling for trials. It's always good if you're going to propose a trial and then you get it funded, you're going to do a trial. What you do is you take this is a hint for any junior investigators. You take the intro to the grant, and then you rework it as a review article, and you end the review article saying what's needed next is X study, and it turns out you're doing that study. It's really, so we did that, and that came out in 2008, and then we could refer to it saying, people have called for a trial of, and so in that, what we did though is we took Ed Wagner's model and we specified the things in chronic care management are in a systems way, and what we would do from a medical, a psychiatric, and a social perspective, and an addiction-specific perspective, and which problems we were trying to address. And it might have been, you can't get to the clinic, or it might have been that your depression is so out of control that we can't manage some of the other conditions that you have, and how we're going to address that, and then what change we might expect, and improved health care and utilization, health outcomes as sort of the end game. So we took his model and applied addiction things to it, and I'll tell you how we applied it in detail, which is why you don't need to see it on this blurry figure right now. So the objective was to test the effectiveness of chronic disease management for people with alcohol and other drug dependence. I might use that abbreviation, CDM. It's a randomized controlled trial in a primary care setting. We had 3, 6, and 12-month in-person follow-up. We screened people at a detox, although we did accept referrals from other places at the medical center and advertisements. So we posted some ads in the hospital, medical hospital, in the emergency department, and so people could come, and in clinics, people could come from other places. And about 75% ended up coming from those who we actively screened in a detox. Most of whom, I mean, obviously people in detox have addiction, so they're potentially eligible. There are some other eligibility criteria I'll tell you about. But they mainly had to have either alcohol or other drug dependence. Those who had drug dependence, met drug dependence criteria, had to be using recently either opioids or stimulants. And those with alcohol dependence had to have some recent heavy drinking. And that was at least 2 heavy drinking episodes, or on average, reasonably heavy drinking on a weekly basis. And that was in the past month. We did not, though, ask that everybody be ready to get addiction treatment. They didn't have to do that. That was not an eligibility criterion. Simple design. We would assess them first before randomization. The randomization was blocked and stratified by substance dependence type. And what I mean by substance dependence type is just, was it drug dependence they met criteria for, or alcohol dependence that they met criteria for? And then they got randomized to this, I'll say again, Cadillac program, this AHEAD chronic disease management program, or usual care. I'll give you more detail about that. So everybody gets an appointment in primary care, partly because we had based this on a study before that suggested if you gave people with addictions from detox appointments with primary care, that they would actually go to them and they would get primary care. We did not detect any other improved health outcomes in that study. But so we gave everybody primary care, and we did a little bit better than usual primary care. If you're familiar with trying to get an appointment in primary care at all, we actually gave people specific appointments. They could choose the gender of their physician. We gave them an appointment within 2 weeks. That's the part that you're not used to, right? 2 weeks. So we gave them an appointment within 2 weeks, and we also offered everybody motivational enhancement therapy, because in Boston at the time, there was no place where you could get that, and we thought everybody ought to have some minimum. But I will mention, for those of you who are already thinking negative study, contamination, problem, what did the control group get? Only 9 people, which turns out to be 3% of the sample in the control group, got even one session of motivational enhancement therapy. So they didn't get MET in the control group, but we had just offered it. And this is a study not of treatment, I should say now, not of the efficacy of treatments. We know that some of the treatments that we offer are going to be should be efficacious because they've been proven efficacious. This is a study of organizing a system of care that includes potentially efficacious treatments. All right. So the intervention group, and there's several slides on what we gave the intervention group, and only one slide on what we gave the control group. So the intervention group gets initial and subsequent care that addresses addiction in large part, but also medical, social, and mental health needs if they were priorities. There was a nurse, a social worker, this is a nurse care manager, an internist, and a psychiatrist. All these people are trained in addiction. Psychiatry, addiction psychiatry, an internist who knows about addiction, a social worker who's trained in motivational enhancement therapy, a nurse care manager who's already been working in the HIV and addictions field. We gave reminders to patients to come back. We coordinated their care. We were available during the day, 5 days a week. People could come in without an appointment, whether they were intoxicated or not. And then we negotiated a treatment plan. Relapse prevention counseling was done at every contact. We offered motivational enhancement therapy 4 sessions and had much greater success in this group getting it to people. We offered pharmacotherapy if it was appropriate for their diagnosis and they were willing and interested. Naltrexone, acamprosate, disulfiram, buprenorphine we could prescribe. And then if methadone was appropriate or that's what they needed or wanted, then we would refer them to a very local, very close methadone program. And psychopharmacotherapy, so basically medication for depression usually, maybe anxiety sometimes. And referrals to specialty addiction treatment. So if this stuff isn't enough and people needed more help, we would refer them to specialty addiction treatment programs in the community, mutual help, so AA, NA, and then of course other medical stuff, so we'd refer them if they needed to other social services, chronic mental health, if they needed a psychiatrist, psychologist, other things we would refer them to. And then again, we'd see them again regardless of whether they were using. So they would be seen in this AHEAD clinic twice, 90 minutes each time. This is in the first week, like rapid fire, like a Tuesday and a Thursday. All 4 clinicians would assess the person And the main goal really was to engage them so they would come back. I talked about these treatments depending on their diagnoses and readiness for them. So this isn't the kind of study where we make sure that you will receive this particular treatment regardless of whether you want it, regardless of whether you're ready, just because you have a certain diagnosis. That's not the way that we offered treatments. We gave them depending not only on diagnosis but also their priorities and readiness. We gave them that primary care appointment as well in the intervention group, as well as in the control group. And then we would follow them up. It was mainly the nurse care manager who would call people back and make sure they were coming, contact them by phone. She would also facilitate referrals, so the warm handoff to treatment programs in the community. As I said, they didn't need an appointment. They could get drop-in care if they wanted. We had a 24-hour pager that nurse care manager carried, access at all times, and we would call them if we hadn't heard from patients in a month. The control group got a piece of paper, a card, that said they were in a study and that they had substance dependence, and there was referral information, like the 1-800 referral number for the state of Massachusetts that gives, it's a treatment locator line, and we advised them that they ought to share that information with their primary care doc so that the primary care doc could then implement any usual care that they wanted. And now these are free living people, so you might even say, well, is that even ethical? But these are free living people. They could choose to go to any treatment that they want to, and I'll tell you how many of those may have, or did, or told us they did. The primary outcome was abstinence from opioids, stimulants, and heavy drinking. So not heavy drinking. They could have been drinking some, and they would still qualify for abstinence by this definition. But we looked at a lot of other outcomes, and I'll wait. I'm not going to list them now. I'll list them when I show you the results tables. All right. And the drug information was actually, at the time it was collected, the primary outcome was collected by the addiction severity, what is that thing? The ASI or something, right? Anyway, whatever. And alcohol was collected by the calendar, timeline follow back calendar method. The statistics slides, actually the only thing I want to point out about this, we used longitudinal models, so we captured information at 3, 6, and 12, and that's what's in the summary statistics. This ASI, I don't know if it behaves here well at TRI, but our statistician was quite displeased because it wouldn't, we tried to transform it a number of different ways, and it would not behave. And so we had to use a proportional odds model for the ASI categories. It was, part of it is because, and maybe, I'm sure you've run into this before, but we had people with alcohol and drug dependence, so that means there's a lot of zeros in some of the groups. So it was a little bit messy, honestly, with the ASI, but you'll see all these models. I'll show you all this stuff in the results. We did pre-specify a subgroup analysis to look at those with alcohol dependence at baseline and those with drug dependence at baseline, and those are overlapping groups because some people had both alcohol and drug dependence. All right, so let's see, you can probably, yeah, I think you can see this one. So people we approached for screening, we screened 2,000, and then these are the ineligibles. So these aren't lost for some reason. They're ineligible, but some of the ineligibility is they weren't willing to establish primary care at our medical center. Maybe cognitive impairment, which was actually quite substantial. They didn't meet the criteria for the study, meaning the drug and alcohol criteria. We require, now we get into small numbers, but we always require contact information for 2 other people who we can contact so that we can get some assistance with follow-up. So 655 are eligible of those 2029. So that's an important number, the 655. Then we lose some people who don't want to be in the study, 85, and we enroll 569. So 86% of eligible. So this should be generalizable, have external validity to people who are eligible for our study, given the criteria that I mentioned, who are at this detox. And some were at the detox. 74% were recruited from detox. The rest from other sites, mostly people who saw a sign in an ambulatory outpatient setting or were referred there by their doctor, or saw another ad somewhere. We had some ads on local buses, for example. 563 were randomized, and the randomization at least worked to give us 282 and 281. in these two respective groups. And actually, the majority in each group had both alcohol dependence and drug dependence. And then follow-up at 3, 6, and 12 months. The rates for each of the follow-ups are listed there. So they're in the high 80s, low 90% rates. And included in the primary analysis is 98 and 99%, because we had at least one follow-up in 98% of people at baseline who enrolled in the study and were randomized. So follow-up is loss to follow-up should not be a problem. Should not be a problem. So this is the table 1, meaning what you would expect. It tells you characteristics by randomized group and overall. So it's easier to look at the overall column. And then after we do that, we can look at what happens 12 months later. So these are people who are 38 years old, 27% female, 47% white, and beyond high school, 27%. 59% had one night on the street or in a shelter in the past 3 months. And let me just point this out. 59% at baseline had one night on the street or in the shelter at baseline. And 12 months later, that's 29%. Okay? So that's just a little foreshadowing of what happens when you enroll people in anything and watch them, especially if you enroll people at a low point in their life, like when they're entering detox. They may be better later. Okay. Health insurance I'm going to skip because it's confusing in Massachusetts. Incarceration, 78% reported ever incarceration, 17% in the past 3 months. We have permission in these and all of the studies that we do to follow people up when they're incarcerated. That needs, of course, special sign-off from DHHS, but we do that so we don't lose people for a reason like that. 83% had PHQ-9 scores that were consistent with moderate to severe depressive symptoms. This is at detox, which of course is better. It's cut in half over time. The mental component summary of the short form health survey from the medical outcomes study is lower than the mean US population average for healthy people, which would be 50. It's 30 here, and over time they get better. Their scores improve, 39. And here's the I think I can't see, but the physical component summary. So physical, they're a little better than mental. 50 is the kind of mean for the US population. So 42 is where they're at, and at follow-up they're kind of the same. So physical status doesn't change much. And about a third have medical comorbid diagnoses. Here's some more, organized the same way, this table. This time it's all the alcohol and drug stuff. I'm going to come back here with you. Let's see. Sorry, you're going to have to. So alcohol drug dependence, let's skip that. Heroin use, 60% in the past 30 days, 2/3 cocaine use in the past 30 days, 11 heavy drinking days is the median. Readiness to change. So look at this. On a scale of 1 to 10, these folks who were not necessarily seeking treatment are 9 or 10. Ready to change, right? I don't think so. My read of the readiness to change literature is that these things really reflect severity. So if you ask people, how ready are you, and they're feeling bad about their addiction and their related symptoms, they say 10. Of course I'm ready. I'd be an idiot if I didn't say I was ready. And so I think that's what you see here. And that's also why in the readiness to change literature you very often find that readiness to change is not associated with change. These readiness to change scales. These people really get me, these readiness to change people, which I'm sort of one of, but whatever. ASI scores are here, 0.5 for alcohol, 0.3 for drug. Now remember, that's the whole population, so some people are alcohol dependent and others are drug dependent, although around 60-ish percent, let's see, yeah, 65% are both alcohol and drug dependent. We use the short inventory of problems, which is a 0 to 45 scale, so 21 for alcohol and 33 for drug out of 45. 30% had ever overdosed, requiring medical attention, 7% in the last 3 months. We assessed HIV risk behaviors, and I'll leave it at that. But one of the things you can still see is that things look better over time. So if you just pick, I don't know, let's pick any one of them, heroin use in the past 30 days. Now this is at detox largely, so 60%, and then at follow-up it's 22%. You might also notice that there don't appear to be huge differences between these numbers in the intervention control column. But this is not the appropriate analysis, but this is just to see what the numbers are. All right, before we get to the main results, these are not, these are the main results. Sorry, these are the main results. So the primary outcome, I just can't see what I'm showing you. This is not the main results. So this is the answer to the question, if you have a chronic care management program and compare it to not, before we worry about do they experience a better outcome, do they receive some of the things that the disease management program is supposed to get them? So part of what they're supposed to do is get more treatments. So let's see. Did they get more treatments? Let's look over here, 12-month follow-up. They're reporting. So any addiction treatment, I know the absolute numbers don't look big, but yes, they actually do get significantly more. They report getting significantly more addiction treatment. Any addiction medication, 21% versus 15% is the absolute numbers. In the appropriate adjusted analyses, it's significantly different, and more people get addiction medication. Not huge difference in the absolute numbers, though. But yes, we were able to achieve getting them more addiction medication. And then the same is true here for both the subgroups of alcohol dependence and drug dependence. They're more likely to get addiction treatment. They're more likely to get addiction medication. And almost everybody made it, well, most made it to a primary care appointment. If you look at alcohol pharmacotherapies, 12% versus 5%. Glass half empty, glass half full. We more than doubled the rates of alcohol-dependent people getting alcohol pharmacotherapy. And we significantly increased the rate of people getting drug pharmacotherapy. That's the half full part. The half empty part is, at best, 12% of those with alcohol dependence only got a medication. Now maybe that's partly because they both had alcohol and drug, and that's a little more complicated to give some of the medications for alcohol dependence for drug, or at least it was at the time prior to naltrexone beginning to be used much more widely for drug. Now these are the actual effects of the intervention on the main outcomes. So the primary outcome is here, which is abstinence from stimulants, opioids, and heavy drinking in the past 30 days. And remember, they're all using at baseline by definition. And 12 months later, 44% in the intervention group, 42% in the control group, so slightly worse, if anything, in the slightly better in the intervention than the control group by 2%. But once you do the appropriate analysis, there's no significant difference. This is the odds ratio for abstinence, which actually suggests, that's why I slip of the tongue, slightly less likely to be abstinent in the intervention group. If you want to say, well, maybe, how about any drinking? If we change heavy to any drinking, no significant difference. Well, all right, how about if we look at the alcohol ASI score? No significant difference. And not only no significant difference, we're talking, odds ratios of 1. How about the ASI drug? Nothing going on. How about mental health function? Nothing going on. This is a linear regression, so continuous scale. What about physical health? Nothing going on there. How about any nights in a hospital? Nothing going on there. How about emergency department visits? 0.96 odds ratio, nothing going on there. There were no differences in carbohydrate deficient transferrin, which I forgot to tell you that we measured. Also gamma-glutamyl transferase. We also did hair drug testing for drugs, which usually reflects past 90-day use of the drugs that you test. And there were no differences there. We did saliva drug testing. There were no differences there. So then we thought, well, let's publish some more numbers just to be sure. Just to be sure. You could start over here with the p-values if you're a p-value kind of person, or if you're more epidemiology focused, you could look for the null effects in this column. There are null effects all the way down, and we'll go back to what these are. There's one. They allowed us to publish to a third decimal place. And it was because it was a pre-specified subgroup analysis, so this is legit. So in the alcohol-dependent subgroup, we looked at the short inventory of problems score. Remember, it ranges from 0 to 45. And at 12-month follow-up, the predicted mean in the intervention group was 10.4, and in the control group 13.1, which is worse than 10.4. And that is significant at p less than 0.05. It's a 2-point difference in a 0 to 45-point scale. I report it to you. There it is, maybe. And my best guess is that it's associated with the intervention, that the intervention was associated with that beyond chance. But we sure did do a lot of analyses. These are not adjusted for multiple comparisons, but that was a pre-specified analysis. So, you know, the other things that were not significant, though, were in these two subgroups, the drug subgroup and the alcohol subgroup. If you looked at abstinence, here we looked at number of heavy drinking days. So maybe it didn't have a huge effect, but maybe we decreased heavy drinking days by a little. Nope, didn't. ASI, alcohol, mental health, physical health, now you're getting used to it. Hospital, emergency department. In drug-related problem score, ASI, mental health, physical health. Okay? No differences. Also by subgroup, there were no differences in the biological tests I told you about. We also looked to see whether among stimulant users, just among stimulant users, did it work among them? Nope, didn't. How about people who had substance-related medical comorbidities? Because that's what Connie Weisner found. The answer, nope, didn't work among them. How about people who had more readiness or less readiness? Didn't work any differently in either of those subgroups. How about homelessness? Because remember, 59% had a night, street, or shelter in the past 3 months. Nope, didn't matter. Mental health-related quality of life, didn't matter. Recent addiction treatment, maybe it worked in them or not in them. Nope, didn't work. Or how we recruited, was it from detox or not? None of those interaction terms were significant. We stratified and looked just to see anyway, even though you're not supposed to do that, and we didn't find anything that looked like anything. There was one substantial significant difference among users of opioids. And this is in the accompanying tables, supplemental tables to the paper. And so it turned out that there was a significant odds ratio of 0.71, but it's in the wrong direction. So the people in the intervention group did worse. They were significantly less likely to be abstinent from opioids. Bummer. And no other significant differences among those with opioid use. Well, maybe people didn't get enough of the intervention. That's actually possible. So of those randomized to the intervention, just about everybody, so one person didn't get the first visit, 75% got a second visit, and 2/3 got a third visit, and then it trails off after that. Maybe that's not enough to get people started. It's possible, but we couldn't also require them. I mean, although in retrospect, maybe contingency management would be a great thing to put on top of a study like this to make sure people come. This also looks at by the number of disease management visits that you were exposed to, did it improve outcome? And we didn't have significant difference here. It did seem, but it's hard to interpret. It seems like if you got 1 to 2 disease management visits, you were less likely to be abstinent, and if you got more, you were no different. So, you know, you begin to do these stratified, and there's lots of analyses here. The big message from this one is probably I don't see a dose-response effect. There's not a dose-response effect, not a dose-response effect that we're missing in the main analysis. When I told, oh shoot, who's the guy in at Columbia? He's a head of a big part of the CTSI at Columbia. Harold, come on. Who? Harold. No, it's not Harold Pearl. No. Harold, he's a psychiatrist. Pincus. Harold Pincus. I told Harold Pincus about this study, and he's a psychiatrist, so he's kind of nice and everything. And he said, well, Rich, it's not the most colossal failure. So now I put an F on my slides because in honor of Harold Pincus. So there were no differences. So was it that people were not ready enough? They weren't treatment seeking? Maybe. I think that's a fair criticism or concern or explanation. The only thing I hate about that is that that's most people. And so if that's true, then what are we going to do for all those folks? There was concern that they were too severe. So 59% night on the street or in a shelter in the past 3 months. They're too severe, except 45% of them are abstinent 12 months later. So are they severe or are they not severe? What's the story? The control group did too well, I just said. About 40%, 45% were abstinent in the past month, 12 months later. Well, why would that be? Is usual care that effective? Is it really that effective? So we'd be comfortable saying, come on out of detox, we'll give you an appointment with a primary care doc, good luck, and that'll be effective. I don't think so. I think it's actually selection, but this is just pure speculation, my opinion, that we were able to find, and it's probably not that hard, we're able to find people who come into detox, the kind of people who are willing to be in a trial, have informed consent. Not that the informed consent changed their outcome, but they're willing to do that. They're willing to come in to 3, 6, and 12-month visits, or say they are, at least up front, willing to get their primary care at our institution, have 2 contacts for follow-up, that sort of thing. And that's why we do a randomized trial, to see if A is better than B. But I think we were able to select people who had a reasonable trajectory and maybe some regression to the mean, because we find them at their worst and then watch the whole group get a little bit better over time. Maybe the intervention exposure was too limited, or, and this applies, I think, to some of the negative brief intervention literature as well, that maybe these things take time, and you got to keep hitting it over months and years, and you won't see the outcomes for years later. I'm upset about this explanation too, though, just like this one, because if that's the case, what do we really need to do? And how are we going to make the case that this is what we need to do if you're not going to see any benefits for years and years? So some of the methodological explanations that are remaining are troubling, the first and the last one, and the others, except for selection, personally, I don't buy so much. But one message is that integrated care, chronic care management is not a magic bullet. It's not something that you say, okay, great, we're going to do this for everyone. We're going to do this for everyone. We're going to have them exposed to 4 health professionals who are super trained. And I mean, that's a major, major investment. So it's not going to be a magic bullet. The other thing is, I think substance use disorders or addiction, let's say addiction, is not one thing. So I looked back at the studies of chronic care management for things like depression and for heart failure is a great example. So when you do a study of chronic care management, and we should have learned from this before we did this study, but we didn't, because this is a lesson from failure. So chronic care management for heart failure studies, what they do is they find people with heart failure who are having recurrent hospitalizations for heart failure. And then they don't just say heart failure. They say something like systolic dysfunction with an ejection fraction less than 35% and 3-vessel coronary disease managed medically. These are folks who actually can be treated with very specific, very effective treatments to prevent recurrent heart failure. So they focus on a specific condition. We studied addiction. And addiction is not one thing. There's diverse stuff going on in there. And probably we can find specific populations. And there's one other thing. I showed this at the National Council for Behavioral Health Care and thought that maybe people were going to throw things at me, but I'm going to say it here too, which is, I know treatment is effective, right? But come on, in general health care, we don't say, yeah, treatment works, treatment is effective. We say things like, treatment of congestive heart failure in people who have ejection fractions of less than 35% and 3-vessel coronary disease and recurrent hospitalizations are effective for those, treatments are effective for those people when you give such and such a dose, right? I mean, it's more specific. It's not just this kind of blanket statement. So if I think about the group that we studied, some of them were people with cocaine addiction. What are exactly the treatments that they would get in the community that would be dramatically effective that we linked them to? And remember, in a system study like ours, we start with a bunch of people in this group. We do our best to link them to services if they want and if they're ready and if they can go and get them. And we really did try to facilitate all that. But then the service has to be out there, and they have to go get it. So you're going to lose some impact there. And then, for those who eventually make it, it's got to be a really good treatment. And so what are those treatments that are out there in our communities for something like, let's say, cocaine dependence? Like, one of the treatments would be what? Outpatient, right? I don't know. What is it? What are the treatments? So, and even when we have an effective, let's say an effective medication, let's say for alcohol dependence, if you want a 10% risk reduction in heavy drinking days, great. But that's a diluted effect, and it's a relatively modest effect. The best we could hope for was, I think, in opioid dependence, people who wanted buprenorphine, getting on buprenorphine, staying on buprenorphine, those people are going to be abstinent from opioids. It's going to work. That's probably the most effective that we could have given people. And we did, but we didn't have something that was that effective for the whole group. Now, there are some promising examples, so don't panic that not everybody's not wrong. It's not what I'm trying to say. But there are a few studies out there that I just want to point out. One is Stephanie O'Malley's from a while ago, where she compared primary care management with naltrexone to cognitive behavioral therapy with naltrexone. The primary care management folks did just as well as the CBT naltrexone people. So this doesn't mean integrated care is better, but it means that you can do integrated care and primary care and get similar outcomes. That was nice. Then David Oslin here, I think, or somewhere here generally, right, just published in Journal of General Internal Medicine this year a study in 3 VAs where, now the slight difference here, he took people who were sort of ready for or willing to accept a referral. So it does select people. But of those folks, people were either getting medication management with naltrexone in primary care versus specialty care. And specialty care included the usual things that happen in specialty care. And in the primary care group, there was actually better engagement and less heavy drinking than in these same people who were referred to, or similar people who were randomly assigned to be referred to specialty care. And then another example is David Feline's work in New England Journal of Medicine 2006, where the study was a randomized trial of 3 different intensities of counseling in the context of office-based opioid treatment, so buprenorphine treatment for people with opioid dependence in primary care. There were no differences between the 3 groups, but imagine, I'm going to draw a y-axis and an x-axis, and you start up here with 100% using opioids. In all 3 groups, it went like this. In all 3 groups with primary care, buprenorphine, integrated care, people weren't using opioids, almost 0. So it can be done. It can work, but what do those have in common? There are specific, proven, efficacious treatments, and they're generally people who have either been referred or are choosing to begin receiving those treatments. So that's where integrated care, I think, the best evidence is so far. So I would not rush, like Sid Charisse and Fred Astaire, to get on the bandwagon of integrated care is the best thing since sliced bread. We're going to do it. We're going to solve all problems. And one of the reasons why I feel a duty to report negative studies is that if you don't, people think that problem is solved. Problem is not solved. We know this problem. I mean, you guys, your institute wouldn't even need to be here if we'd solved the problem. We haven't solved the problem. On the other hand, in this case, and she says here, I've heard this saying, but I never thought it was something that could actually happen. She threw the baby out with the bathwater. So I would not throw the baby out with the bathwater here. I think integrated care definitely has a role. Longitudinal chronic care management definitely has a role. When we published the study in JAMA, some people said, hey, Saitz is saying that this is not a chronic disease. No, I didn't say that. Our study doesn't say that. Study doesn't say that. So integrated care and chronic care management, I think, must be better. It has to be better. It just has to be better. But the evidence is largely limited to addiction specialty settings right now. It's not going to solve all our problems. This is a tough one because we don't really have an answer to this one. It's only as good as our treatments because it integrates the care that we have, that we can offer. I think it is promising right now today for specific disorders with specific effective treatments. Probably, I hate to say, in help seekers, because this goes against my grain, the grain that, that I subscribe to. And maybe, I don't know about this one, maybe there's some that it works in the right band of severity, like not too severe, but not too mild. I'm not too sure. I don't have a whole lot of evidence for that one, but maybe. And I'll just leave this one up here, because if you guys want to subscribe to a free NIH-supported bi-monthly summary newsletter by email, you can do that at aodhealth.org. And here, you could submit papers. It would be really good if you submitted papers to Addiction Science and Clinical Practice, which used to be NIDA's journal, but now Jeffrey Samet and I edit this thing, and we're really aiming to publish stuff that addresses improving quality of care for people with addictions. And if you want, these are not, so those were shameless self-promotion. These here are not related to me at all, but this is one of the sites where, that's what it is, Center for Integrated Health Solutions. That's CIHS, where there's a lot of information, bibliography, and stuff on integrated healthcare. And then these guys at UMass have a site on, it's really interesting, they have a big program on training people who've been in the addictions field to work in primary care, and most of it is like cross-cultural. It's like they're training them to go to France or something, and to say, like, how do you act in these settings, and what's the culture, what's the language, all that. So it's kind of interesting stuff, and I'll stop there. Thank you. Take questions.